We will now launch our panels, starting with the first one on the decisional context. I'm moderating that panel and am delighted to have three panelists that were part of this effort. And the first who will be speaking is Fernando. Looking for Fernando to be able to launch his talk. What we'll do for these talks is we'll have the three panels, it's a lightning round, each presenting for several minutes about their project, and then we'll follow with question and answer. Please put your questions into the question and answer box, and uptick questions that you'd like to see answered if ones are particularly appealing to you. So we will start this process, and our first speaker is Fernando Olarid Escudero. Welcome, Fernando. We welcome you and your team to tell us about your project.
Hi, Kathy. Thank you very much for the introduction, and thank you for the opportunity to speak here in the opening session at SMDM. And hi to all the colleagues and that are joining this session. So I want to start by saying that I'm at the Center for Research and Teaching Economics in the city of Aguascalientes, Mexico, and I will talk about how we establish a dynamic decision-making system in real time on the COVID-19 pandemic in Mexico City metropolitan area. The reach of our focus of our project focuses not only on Mexico City, which is shown in gray in the slide projected by Kathy, but on the whole Mexico City metropolitan area, which includes Mexico City, the counties in Mexico City, plus 59 neighboring counties or municipalities, they are called in Mexico, they're in darker gray. Next, please. I want to thank my colleagues from the Stanford CDEC Coronavirus Simulation Modeling Consortium for their valuable contribution to this work. Next, please. To put the audience in context, Mexico City metropolitan area is the most populated city with more than 20 million people, which is one of the greatest and most populated metropolitan areas in the world, has the highest population density in Mexico, and contributes to more than 20% of Mexico's gross domestic product. In terms of COVID-19 burden, it has the highest number of cumulative cases with more than 180,000, and cumulative cases up to date of more than 19,000 deaths in the country, with a case fatality ratio of approximately 10%, which is one of the highest CFR compared to other cities similar demographic characteristics in the world. In mid-March, we started collaborating with Mexico City metropolitan area government officials, advising them to develop their own COVID-19 epidemic model to project out different policies they were interested in evaluating at the time, like mid-March. The model was crucial to guide mitigation policies at the time, but as the epidemic has evolved, there's been a need for more realistic models that can inform detailed and timely relevant policies. Thus, the need for using our Stanford CDEC Coronavirus Simulation Model, or as we call SC-COSMO, to project outcomes for more detailed interventions, such as decreasing social distancing in workplaces, reopening schools, and to be able to guide, to predict, to generate projections using a realistic model. Based on conversations with officials at the metropolitan area, they expressed interest in midsummer in projecting school openings halfway fall semester, resume in-person work for government officials, and a combination of both. What we did then is we used our SC-COSMO model to calibrate or to fit or adapt our model to the epidemic in Mexico City. To do so, we used a Bayesian calibration approach that would allow us for probabilistic projections to quantify and propagate uncertainty, which now we know based on the great keynote speaker presentation today that is important and relevant for making decisions. We conducted internal validation of our calibrated model by comparing model predicted outputs to the incident and cumulative case series. Next, please. Two more clicks. One more. What we then is also generate projections on hospitalizations. Next, please. Onto total hospitalizations and also hospitalizations with ventilator. Two more, please. So we saw, based on our projections, we saw that cases will start going down slightly at a lower pace, but we found that we will have a decreasing trend on the projected incident cases, which will affect also the total hospitalization occupancy. Next, please. We then simulated different mitigation or non-pharmaceutical interventions. Next, please. In which the NPIs, which we call non-pharmaceutical interventions, will start on November 2nd. These NPIs consisted on, we evaluated 3 different NPIs: resuming in-person schools, decrease social distancing by 50% relative to the social distance level estimated by September 20th, and a combination of both resuming in-person schools and decrease social distancing. The effect of NPIs will have an increase in incident cases shortly after implementation. Resuming in-person schools will yield the lowest increase in both cumulative cases and deaths, followed by decrease in social distancing. Combining both NPIs will yield the highest increase of both cumulative cases and deaths. We estimated that all NPIs with resuming in-person school might yield saturation of hospitalization by the end of the year. However, it is likely that by only resuming in-person school, saturation of hospitalization might not occur until next year. Hospitalization has been one of the key drivers of policy decision-making in the epidemic in Mexico City and in the rest of the country. So it's one of the indicators people and the officials are using to make decisions and guide how much they open and reduce the effect or the intensity of NPIs. We're still in communications with our colleagues and officials to further implement different strategies and scenarios based on current interest and interest that will happen in beginning of next calendar year. And thank you very much for the opportunity, and we thank the More Foundation for the opportunity to be able to implement our project and conduct all these analyses to help guide decision making in real time in Mexico City metropolitan area. Thank you.
Thank you so much, Fernando. I was very pleased to hear your presentation, and I'm sure that we'll have lots of questions about what you're finding and how that's going with the context that you have in our question and answers. Now I would like to turn to our next presenter, Turgay Ayer from Georgia Institute of Technology, presenting for his team that included Jagpreet Chotwal, who is also leading that team. Turgay, could we have you give us a glimpse at your work in this parallel area of trying to help policymakers with big decisions?
Sure. Thank you, Kathy. Good morning, everyone. My name is Turgay Ayer. I'm a faculty member and Director of Healthcare Analytics and Business Intelligence at Georgia Tech. Next, please. And our project is titled Informing COVID-19 Testing and Contact Tracing Using COVID-19 Simulator. This is a large team effort led by, in addition to myself, Jack Chotwal from Harvard MGH, who couldn't be here today for personal reasons, Ben Linus from Boston Medical School, and is contributed by several other excellent team members, mainly from MGH and Georgia Tech. Next, please. So we started this project around March, and our biggest objective really was here to develop an interactive model for policymakers and stakeholders that is updated in near real time as evidence becomes available. Our tool is available at this website, covid19sim.org, is updated on a regularly basis, on average once a week, based on the most recent available data, and updated again also based on most pressing evolving policy questions over time. And unlike most of the publicly available models, users can actually go ahead and run our model and run different what-if scenario analysis, either at the national level or for specific states in real time. Our model is included in CDC COVID-19 dashboard, along with a few other models. It received widespread media attention, and in addition to several other outlets, it was covered in Rachel Maddow show. And just on that day, it received about 20,000 hits On average, on a daily basis, our model is accessed by about 100 to 200 users, which we know to include users from departments of public health from various states, as well as from some state senators' offices. Next, please. As I noted, users can actually go ahead and run Whatif scenario analysis in real time using our COVID-19 simulator. Let me illustrate this using an example. Here we are looking at a specific state, Wisconsin, and we have assessed the impact of 2 weeks of lockdown, excuse me, 2 weeks of lockdown in Wisconsin over the next 4 months in comparison with the current set of intervention. So in scenario A, we are looking at current set of interventions, whereas scenario B represents 2 weeks of lockdown followed by current set of interventions over the next 4 months. Among several other outcomes, the users can see, as we see in this slide, what happens to overall death, cumulative number of cases, hospitalizations, and ICU bed utilization. There are other outcomes that we report, such as active number of cases, daily cases, etc., that are not covered here for brevity. And as we can see here, if we compare scenario A versus scenario B, we estimate that just the 2 weeks of lockdown in Wisconsin may reduce cumulative number of deaths and cumulative number of cases by about 1/3 in the next 4 months, as we see in the left panel, and may also reduce hospitalizations and ICU utilization substantially, and particularly may prevent ICU overutilization over the next 4 months. Next, please. We have recently modified our model to also estimate state-specific seroprevalence rates, as we see in this figure. And as we observe, the state-specific seroprevalence rates are estimated to range somewhere between 0 to 20%, and it is highest in New York and New Jersey, and is around 20% in these 2 states. So that is pretty much all we wanted to say today. Thank you all for your attention.
Thank you, Turgay. It was very interesting, and we look forward to, again, hearing questions from our audience. I see that we have an incredible number of participants here, and I look forward to hearing more from the participants in response. I'm encouraging everybody right now to put your questions in. As we move to our third recipient of grant funding through CDMI, the team is led by Lauren Cipriano and Eva Enns, and they will go ahead and present a glimpse at their project. I'll turn it over to that team now.
Thank you very much, Kathy. Eva, Well, and I have an amazing team using a dynamic compartmental model to develop community-tailored strategies for managing COVID-19. Next slide. The amount of transmission risk in a community is determined by several features, but notably its base level of hospital and critical care capacity are indicative of how much risk the community can take on, and its goals regarding the ability to operate other aspects of the healthcare system that can generate critical care patients, such as elective surgeries. Operating only essential services and essential employment does not result in the same base risk across communities. Some communities have higher density housing, more interaction with neighboring communities, older age distributions, or more essential businesses, such as a specific type of manufacturing, or conversely, more individuals employed working from home, or who can work from home. Then, as each community decides what additional risk activities, and by that we mean non-essential in-person employment sectors that return to work, education and childcare services, culture, restaurant, and entertainment services permitted to reopen, and what size of gatherings for religious services or family celebrations, the absolute size of each group and the interactions between those groups in the community makes community-specific differences. For many reasons, opening bars and restaurants in Miami Beach or Nashville is not the same as opening them in Stratford, Ontario, which is also a tourist destination, but a city whose tourism is focused on sit-down restaurants and theater versus bars. As each community element is added, the potential for exposure to individuals seeking essential services like groceries or who provide essential services like police and transit workers increases. And as a result, we may see differential risk based on the same factors we already know to cause health disparities. With our dynamic transmission model of COVID-19, in which the adult population is not just age stratified, but stratified by employment sector, we hope to evaluate the importance of community-tailored solutions in creating sustainable COVID-safe communities. And we're working with stakeholders in different communities across Minnesota and Southwestern Ontario to help guide the community-tailored solutions for these communities. Next slide. One example of our work to date is focused on estimating the impact of student populations returning to mid-sized college towns such as London, Ontario, in a scenario in which students double their contacts for just 2 weeks and then reduce their pre-COVID contacts by 24%. The total number of cases in a mid-sized college town can more than double, with 2/3 of those cases attributable to the student population occurring in the non-student population of that city. Consistent with other groups, we find that high frequency screening prevents 40% of those incremental infections, but it requires so many tests that here in London, Ontario would not be a cost-effective option. A one-time mass test screening event would provide moderate benefits, but those would be cost-effective benefits and would provide information from which to inform future testing scenarios. Next slide. Focusing on the decisions on October 1st, having not engaged in a mass screening strategy, reducing students' contacts further through public health messaging is not able on its own to maintain critical care utilization below 30 beds, which in this community is the threshold at which we need to begin reducing access to elective procedures. Next slide. And because the spillover infections compounded in the student population has already occurred, we now recommend population-wide staged social distancing strategies where early moderate actions combined with targeted interventions in high transmission communities and high consequence communities are able to prevent more drastic economic shutdown events in the future. Thank you, Kathy.
Great, thank you, Lauren and team. We are now going to move into some questions and answers with our 3 grantees, and I want to just let everybody know also that there's a chance later on in the day to go to a breakout session with the teams and the groups that are most interesting to you. You'll have 2 chances, so you can go to see 2 different teams. But if you have questions for some of these projects that you might not be able to ask in those breakout sessions, this is the chance. I'd like to start with one of our audience questions here. We have a question to Fernando from Sean Dwan. About how receptive has the Mexican government been to the tool that you've designed and the work that you've done, and has there been any pushback?
Yes, hi Sean, thank you for your question. Fortunately, the collaboration has been very organic. They started actually reaching out to us for help on modeling these different interventions, knowing that we had a realistic model with different components and how the population is mixing. So they have been quite receptive, and we are in continuous communication with them. And there's another question there, which I'm going to tie my answer to on the use of data. So we are in contact in constant communication where, to be able to answer certain questions, we might need additional data, and they have put some efforts into gathering that data, collecting it, or even summarizing or synthesizing, so we're able to use it in our models. So in our case, with the collaboration with the Mexico City official has been quite a good experience, and they've been quite receptive.
Fernando, thank you for moving into that other question as well about data, and I'd like to open that up to our other 2 panelists as well. So the way the question was asked is that models are only as good as the data that is used. So what opportunities have you seen for your groups to advocate to funders to be able to get the best available data? And just in general, how have you been helped to get the data that you need to do your models in a way that is responsive to the decision makers you have? I would like to hear a little bit more about the data side of making sure to be able to meet the needs of the decision makers, and how you know that you're meeting their needs based on the data that you're getting. Any comments on that? Sergey, I might start with you, if you don't mind.
Sure. So that's a good question. That's a very fair point.
I think we may be having a little problem.
For some, can you hear me fine?
Oh, go ahead.
Can you hear me fine now? Okay. So I was saying that this is a, yeah, it says, maybe we can switch over to another panelist. It says my connection is unstable.
Your connection's a little bit, yeah, it's having a little trouble. Yeah, let's
yeah, it says unstable. Yeah.
Okay. I know that's a little difficult. That's part of our Zoom world now.
All right.
Getting big. big packets of data through is challenging. Yeah, Lauren, would you like to go?
So Kathy, I would say that one of the amazing features of models that we've all been the beneficiaries of for a long time is models with high uncertainty on data and not necessarily having the ability ever to rely on great data. And so we can use our models to incorporate that uncertainty into the parameters, into the structure. And I think that one thing that we're often pressured to do from stakeholders is to try to provide them precise predictions of the future. And I think remembering that we're modelers, but not part of the witchcraft is important in keeping perspective. The best use of our models is not necessarily predicting what's going to happen exactly in 2 or 3 weeks, but in doing comparative analysis. And often, regardless of that exact prediction, the comparative analysis gives us great insight into what strategies are likely to have the best impact. Even if we are not able to tell you exactly where that impact is going to be, we know that one strategy is going to be more effective than another, including and incorporating all that uncertainty into the analysis. So I think we can work in these data vacuums as modelers. It makes it more difficult to communicate, but it allows us to use our models for policy comparison.
Yeah, I can chime in and add to Lauren's points. Can you hear me fine now? Okay, so we probably have heard the famous saying by George Bucks that all models are wrong, but some are useful. And that's very true in this case, basically supporting what Lauren said. Even if we have parameter uncertainty, we could run extensive sensitivity analysis, robustness checks. And in my opinion, we should rely on the qualitative findings more than the quantitative exact estimates when assessing model outcomes implications, right? If you are seeing that if you do this intervention A versus intervention B, if there is a sizable difference, estimated difference, our estimated difference may not be precise, right? It may be subject to parameter uncertainty, but if 5 models out of 7 is saying that it makes a huge difference, probably there is some ground truth to it. So in that regard, again, the precise model outcomes may be somewhat deviating from ground truth, but in terms of the qualitative implications, it may be helpful. And also, I would say that the biggest challenge for many parameters, we have some good understanding from published literature, from epidemiology literature. I think the set of parameters where we have highest level of uncertainty is the intervention effect, because we are looking at a counterfactual world, right? What happens if all schools are opened? What happens, if let's say all college classes resume? This is a counterfactual world. We haven't observed this world. So we cannot directly estimate parameters, and it's hard to run randomized control trials in this setting, but there are empirical studies, econometrics-based, either, difference in difference type of methods or regression discontinuity type of setups, which compares the effects of interventions in 2 counties, 2 neighboring counties with different interventions. So even in the absence of these randomized control trials, empirical evidence tells a lot about the potential implications of these interventions that we haven't observed at wide scale.
Thank you. Thank you. We have a question that I think is really fascinating in this particular moment in time from Scott LaJoy. It's to Lauren and Eva, but I'd like to open it to everyone. Thinking about super spreaders and super spreader events, are your models considering that, and how are they considering it, and what are you finding in terms of decision maker interest in that part of the modeling activity? If you've had that kind of handshake with decision makers, is that an area of interest?
So we have 2 versions of the analysis that we've done in the past that incorporate super spreader events. One of them was a deterministic super spreader event on a very specific day, just to illustrate what that meant to decision makers. So on a very specific day, I could do a super spreader event with 100 new infections and show them how that impacts the future trajectory. And so that was more of a way of illustrating and communicating with decision makers. In another analysis that we're doing to try to look at what does a high pressure situation in the hospital look like 6 weeks coming, we also incorporate that, and we just do it as a Poisson arriving event with sort of a random number of infections. And so parameterizing the probability of such an event and exactly what its size is ends up being one of those difficult uncertainties. But adding that noise to the system, I think, is really helpful in trying to make sure that we capture that uncertainty as we're trying to do that signal to noise prediction.
Fernando, do you have any comments on super spreaders in your model or super spreader events? Is that something that's...
Yeah, sure. So we currently don't model specifically super spreaders, but a way to do so is we've had these conversations on stratify these infectious folks to whether their likelihood of spreading or their infectious probability will be higher by a certain amount. And if we can match that combination of non-super spreaders and super spreaders, try to match the aggregated by knowing those super spreaders, what's the evidence on how much people or how many people they have infected, and come up with a combined or heterogeneized compartment by accounting for super spreaders. But yeah, definitely it's doable.
Great, thank you. Terje, any comments on the super spreader issue?
Sure, very briefly. So we don't model super spreaders either in our tool, in our model. I would say that most of these models are compartmental epidemiological models that models cohorts instead of individuals, heterogeneity in the population. From a macro level perspective, I would say that it wouldn't make a huge difference if 2 people spread the disease. Let's say if 10 people spread the disease to 2 others versus 1 individual spreads the disease to 20 others. On average, the average effect size would be similar. And if you are interested in the average effect size, I would say that wouldn't matter. But if you are interested in targeted interventions for that super spreaders, who we don't know they are in the population at this point, then that makes a difference. So just to wrap up, our model is a compartmental macro level model that doesn't capture, and depending on the research questions, the type of research questions we are interested in are not very much related to targeted interventions for targeted subgroups.
Great. Well, the next area of questioning that I'm seeing and would like to expand a little bit, Ram Shrestha has asked about commenting on the possibility of COVID-19 modeling at the zip code level, where people might respond more effectively to prevention measures. What I'd like to do is expand that question just a little bit and ask you about, in your work with your decision makers, are you seeing an interest in being able to drill down into smaller and smaller, either geographical regions or other ways of looking at smaller groups that may be where the action can happen? Is that something that's going on in your group, trying to get to that more localized point of being able to have action, and how is your decision model effort working to do that, if it is?
I can respond to, yeah, go ahead, Fernando. Go ahead, Fernando.
Okay, thank you, Sergey. Yes, so at the beginning of our work in mid-March, we were asked to model Mexico. Could you help us model the epidemic in Mexico? And at the time it was tough to come up with just one single model for the whole nation, given like how big it is, 120 million, and how heterogeneous it is and geographically dispersed. So we had this argument back and forth with policymakers at the time that it was not really that useful to model one epidemic as a whole. So the idea was to try to stratify that epidemic and at least do state-specific models. We also have geographically divided by states, so it's like state-specific models. And if we were focusing on one state, the idea was to, are we able to stratify either by regions within the state or by counties or municipalities? And that's what we've done both in Mexico and in other settings. For example, in California, led by germ eagle hybrid fever, done county-specific models to then aggregate and project out what the epidemic looked like in California. For Mexico, we've developed overall state-specific models, implement them, and then come up with an aggregated projection of Mexico as a whole, given that different states are at different phases of their epidemic, and they might have different MPIs implemented at different tests with different intensities, and might respond differently to these MPIs.
Thank you, Fernando. Were there any other comments on this in terms
that,
of other?
Yeah, so I can speak to that briefly. We have recently started a related project, an outbreak detection tool at the county level that's also available at our website, covid19.sim.org. So for compartmental models, they are parameter heavy, right? They have many parameters, and while it's ideal to do the estimations at the county or zip code level, it is hard to parameterize such parameter heavy models at the county or zip code level. So instead of that, what we did is we came up with a more sparse machine learning based model that requires significantly fewer number of parameters to detect outbreaks at the county level over time by looking at the doubling time, case doubling time. So we are looking at only a single parameter, and we have a good understanding of how cases are growing. And for case doubling time, we have a good understanding. We have validated the model. We have seen that we can detect some of the outbreaks much earlier than they've been covered, identified covered in media outlets. And this is currently up and running. We have launched that tool about 2 weeks ago or so.
Thank you. And Lauren, I'm going to just pivot for you, since there was a question directly to you about wondering about whether you can test cost effectiveness of strategies like wastewater testing in university dorms, because that might be more cost effective if less individual testing would be needed. That's from Jennifer Lobo.
I think wastewater is still in early stages. I think a lot of communities are trying to use it to detect. I think so far it's detecting that prevalence is rising in those communities, which is already usually known at the time that the wastewater is coming up positive. I think only until we can do wastewater at that type of level where that she's talking about, where we're looking at individual apartment buildings, are we going to get close enough to identify where we might see a cluster of cases inside? And I think that that's likely a fairly cost-effective strategy to be looking at sort of high density residential settings like that. But we don't have the capacity right now to deal with that. I think we would need a more spatial network design to do something like that. And I think there are some models out there like that, but not in this group to my knowledge.
Wonderful. We are at our time. I want to thank the three of you for your presentations and for the very interesting discussion. I want to thank our participants in the conference for their questions. There were a few questions we didn't get to. I will say to Hari's question that the groups by this whole cohort of modelers are getting to hear what each other's working on and have a Slack channel and are exchanging information. So the possibility of collaboration and working to compare models is for sure part of the potential, and the engagement of the wider SMDM community would be wonderful. So I just want to point that out. We will have a break here until 10:50, and then we'll start up again with the next panel, which will have the methods focus, and Jillian Sander-Schmidler will be moderating that. So please take your break in this Zoom world. We all need that. And thank you for your attention. And again, thank you to the panelists. Very much appreciated.